Welcome to This Week in Health IT. It's Tuesday News Day, where we look at the news which will impact health IT. Today, we've got so much going on. We're going to talk a little bit about the Optum naviHealth deal. We'll talk about, people coming back to the hospitals, at what rate and what things to look at. We're going to look at American hospitals' expansion into China. We're going to look at CMIOs, comparing notes in Philadelphia, and some other things. My name is Bill Russell, Healthcare CIO, coach and creator of This Week in Health IT, a set of podcasts and videos and collaboration events dedicated to developing the next generation of health leaders. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. It is their commitment to making this content available that has made the daily episodes possible. Special thanks to Sirius for supporting the show's efforts during the crisis. I want to thank those of you who sent over stories for me to cover. It is extremely helpful. I really do appreciate it. If you find a story that you think I should cover on this show, please shoot me an email with a link to bill@thisweekinhealthit.com. If you have a reason you think the story is important, please share it with me as well. That is really helpful. Okay, let's get to the news. There's a lot to talk about. All right, we'll start with Optum buys naviHealth. So I'm getting this from two places. I'm getting it from the Becker story, Optum buys naviHealth, 5 details, and I'm getting it from A Healthcare Z. Dr. Eric Bricker does these videos, and I love them. And they keep showing up in my LinkedIn feed. I finally signed up for them, and I contacted Dr. Bricker, and we recorded a show. So you're going to be hearing from him in the next couple of weeks. So let me give you a couple of the details here. So Optum bought naviHealth. naviHealth is a company that does post-discharge for Medicare Advantage clients. It was founded in 2012. Founded in 2012, 2015, Cardinal Health invested. I think they bought like 75% of the company at a valuation of about $400 million, which is a huge success story in and of itself. In 2018, it ended up with a PE firm. And the deal that Optum did with naviHealth values the company today at $2.5 billion. So think about that: 2012 to 2020, 8 years, $2.5 billion valuation. It is just really amazing. naviHealth, what they do is they develop software to track and coordinate patient care after discharge from the hospital. It also coordinates bundled payments for episodes of care. The company manages post-acute services for about 4.5 million Medicare Advantage members and serves more than 140 hospitals in the CMS bundled payments for care improvement advanced program. Okay, so that's some of the details. Here's what I loved about Dr. Bricker's analysis. He talked about the reason he feels like this was successful. First of all, and this actually gets into my so what. The first thing is, this is a big number in and of itself, but this is during the pandemic, and Optum has the money to purchase naviHealth for $2.5 billion, or at a valuation of $2.5 billion. I think only $1 billion or something like that changed hands. And then Dr. Bricker sort of broke this down, which I really liked. He said, they defined a very solvable problem, which was readmissions. Then they created a business model that really worked for a lot of health systems. They went at risk. They went at risk for Medicare Advantage population. And how that works is the government gives a lump sum to the health systems to take care of this Medicare Advantage population. If they can reduce the cost, they make more profit. And where naviHealth came in with the business model was to essentially say, we'll keep a percentage of that profit, but we're driving your profit up as a whole. So that was the second thing. The third thing he talked about was how they had a perfectly connected and involved investor in Tom Scully, who served in both Bush administrations. He ran CMS, Federation of American Hospitals, and whatnot. So they had an active investor who was very well connected within healthcare. That's how you get to 140 hospitals, 4.5 million Medicare Advantage members. And then he finally got to talking about the software, data analytics, and the software. And it's interesting, that's the fourth priority in there. And he makes that point that the software really follows defining a solvable problem, creating the right business model, having the right people on your board or in your leadership team, and then creating a model that works. The other thing that they did, which was pretty effective, is they didn't rely only on the technology. They actually put humans on site, right? So, and they didn't rely on the health system's staff to figure it out. They put humans on site who utilize the software to drive those savings. Pretty successful model, interesting one to follow, and that's the reason I do that as a so what. It's it's an interesting formula for health tech startups to consider, and I believe he's right. I think it is. I think that model, solvable problem, good business model, at risk, or just good business model, a highly connected board member or leadership, and then the software. The software has to be good, but I think too many tech startups move that software up to number 2, even number 1, and they think, oh, the software will win the day, and it doesn't. It is really about the business model and having the right business problem. All right, story number 2. I'm going to try to move through these stories. I've gotten a little lazy and only doing 3 or 4 stories. I'm going to try to do a little bit more today. So Kaiser Health News, about half of the public says they have skipped or postponed medical care because of the coronavirus outbreak. And in fact, I think that's all I'm really going to share from this. If I go to this story, nothing really. I mean, I'm not going to share with you anything that you don't already know. They asked the question, in the past 3 months, have you or your family member in your household skipped or postponed any type of medical care because of the coronavirus outbreak? And as you would imagine, close to 50% said yes, they have. I think the so what on this is I don't think we're all just going to be able to sit back and all of a sudden these people are going to magically appear on our doorstep. I think we're going to have to create campaigns to do outreach. We're going to have to go out and get them back into the pipeline, get them back into the workflow so that they schedule those appointments, schedule those procedures, and come back in. So I think that's going to be a key to restoring revenue and restoring the revenue streams quickly, which I think is going to be important. Next article, and I think this is an interesting one as well. This somehow made it into my feed. I'm not sure how, but it did. It's from The Wire, China, and the story reads, American hospitals take the China road. Let's see, it starts with, in a Chinese medical market predicted to be $2.4 trillion, which is most likely the reason why American hospitals are taking the China road, $2.4 trillion. More famed U.S. clinics team up with private companies to get in on the action. Okay, so this is a diversification strategy. That's what's going on. Let me give you a little details of what's going on. The U.S. hospitals are coming to China at a time when the government is relaxing restrictions on who can provide medical care, according to a report published last year by Deloitte, the consulting firm. About 2/3 of the country, approximately 35,000 hospitals, are now privately managed. While few American hospitals make detailed disclosures about their Chinese ventures, analysts say that most of the deals consist of lucrative consulting agreements in which American medical institutions provide support and advice on hospital management and clinical practices. In addition, Chinese hospitals often pay a hefty licensing fee in order to affiliate themselves with the brand name American hospitals. So let me give you let me pull this up in my browser, and I'll give you a couple of the deals. They have a nice little chart in the middle of this thing. Hospital deals and partnerships. In 2012, Massachusetts General Hospital out of Boston did a partnership with a hospital in Shanghai. Brigham and Women's, associated with Harvard, did a deal with Evergrande Health in China in 2015. There was a consulting, and that was a consulting and licensing agreement, consulting and affiliation agreement with Mayo Clinic out of Rochester and Sir Run Shaw Hospital in 2017. In 2018, we saw 2 significant deals, Cleveland Clinic and another hospital in Shanghai, and Mount Sinai Health out of New York, and Taikang Healthcare in Nanjing was a consulting and licensing agreement. And then finally in 2019, you had UPMC do a significant deal with Wanda Group, and that was consulting and revenue sharing when I read this article, none of that really surprised me. We'd been talking about this for a while. These are significant deals that diversify the revenue of health systems, and that's what they're looking to do. They're looking to diversify, not be as tied to the American healthcare market and the reimbursements that are there. These give them another revenue stream. These are going to continue to be the norm as countries climb the affluence ladder and seek better care. China is not the only location this is happening in. I think everybody knows that. We've seen some partnerships in the Middle East. We've seen now partnerships in the UK even. The brands alone represent significant value. And so this is unlocking the value of the brand itself. But eventually it will be things like digital care pathways and solutions that make these partnerships even more valuable. The reason I have it on This Week in Health IT is, I think technology leaders will have to become more adept at really understanding the different geographies, regulations, and cultures in order to create value for these types of partnerships. So that is just something to keep an eye on. I think that's going to continue to grow. As I said, we are exporting healthcare around the world, regardless of how bad you hear it is. The brands are strong. The care that people receive in America, they used to travel thousands of miles to come to America to get the best healthcare in the world, and we are now exporting that knowledge and that expertise around the world. So that's going to continue. Next story, strength in numbers. Philly area CMIOs see value in collaborating. So let me pull this one up. Take me a second. Here we are. Healthcare Innovation, which is a group that I pull a lot of stories from. This is David Rath's. So strength in numbers. Philadelphia area CMIOs see value in collaborating. Progress by 9 health systems on data sharing paying off during the COVID pandemic. I'm going to share this because I believe we saw a lot of collaboration happen during the coronavirus pandemic, and I think that's going to form the foundation for ongoing collaboration between health systems, and I think this is an interesting one. So I'm going to read a little bit here. So in early 2018, 3 Philadelphia area health systems all went live on the same EHR vendor. With the addition of these 3, there were a total of 9 health systems using the same EHR vendor in the region. We decided the time was right to bring together the CMIOs and assistant CMIOs for these 9 health systems. Beddish, I should probably say who that is. Let's see, Joel Beddish, MD, Medical Informatics Officer at Penn. Beddish said, just within the city of Philadelphia, they could bring together Penn, CHOP, Jefferson, and Temple. You can see how easy it is for patients to have a primary care provider from one health system and see a specialist at another, he added. In the spring of 2018, they sent out an invitation to CMIOs and assistant CMIOs of 9 Philadelphia hospitals, systems comprising a total of 17 hospitals using the same EHR vendor. Their first meeting took place in July of 2018 with 20 attendees. For a few people in the group, they were meeting people in person. They had been emailing for years. The first meeting was devoted to creating a list of topics of mutual interest. All right, so they got together, created the list of topics with mutual interest. These topics fell into 4 categories. The first was EHR enhancements that require regional cooperation to accomplish. A good example involves sharing clinical records with each other. We proposed making an agreement that all patients would be automatically opted in to free sharing with the rest. Also, communication with each other via direct address across instances of our EHR, and also linking local resources to social determinants of health in our EHR, Beddish explained. Another issue was how to get the EHR data from the recently closed large academic hospital, Hahnemann University Hospital. The second category revolved around currently used EHR features, including reconciliation of medication lists with each other, which may sound simple, but it's surprisingly complex. Okay, let's get to the third. The third category was the potential use of new features such as real-time prescription benefits and cancel RX, which means if Penn Medicine cancels a prescription in its EHR, that information will get transmitted to the pharmacy. Obviously great for really handling the opioid epidemic. And then the final one was collaborating on regulations. Interesting framework, interesting model. I think I shared the whole model with you because I think it's a good place to start. If you have come together as a result of COVID and now you're stepping back, it's it's a good way to think. Their framework was pretty simple, but I think yielded some good results. The one question I have is, does it have to be centered around a common EHR? Obviously, I think, it may be centered around the EHR because the collaborations are just easier, right? And they really don't rely on complex projects that require HIT to participate. In many cases, the collaborators are connected directly with the HR providers. They can make requests. They can make little changes here and there without the use of health IT. I think it's also interesting, CMIOs, associate CMIOs, and no technology players are at that table, even though an awful lot of it is going to take place across the technology. I'm not saying that's a bad thing. I'm saying that I think that's a common thing that we have to be ready for and understand that it is happening. All right. Healthcare giant Keiser Permanente considering private wireless LTE network. Let me pull this one up. Here we go. This is interesting to me. So, Kristen Klein is in charge of a network strategy for Keiser Permanente, the nation's largest nonprofit health plan with 12 million members, 39 hospitals, 84 billion in revenue. He recently completed Cornell University's 5G for Business online program. But when he thinks about how wireless technologies can solve business problems for Kaiser, 5G isn't the only technology that he's keeping an eye on. So I find this interesting because what he goes on to talk about is how there's a spectrum, the 3.5 gigahertz spectrum band that has been dubbed the Citizens Broadband Radio, CBRS service, CBRS. People are talking about 5G and they're talking about Wi-Fi and connecting up all these devices. But he goes on to say, patient monitoring and critical communications are the use cases that Klein needs to support with robust networking technologies. Currently, most of Keiser Permanente connected devices use cables, dedicated wireless frequencies, or Wi-Fi. We've been progressing Wi-Fi because we have to be really good at it, and we're going to have to be really good at it going forward. But I see an impending wave of additional devices, and we're going to have an answer to how do we deal with that, said Klein. CBRS came at the right time to be a potential answer. He goes on to talk about how CBRS could potentially offer more secure and more reliable bandwidth within the hospital, given all the challenges that are there. Now, interesting story. What do I like about this story? The thing I like the most about this story is thinking outside the box. I'm not sure about the solution, really, to be honest with you. It's a little bit beyond my technical pay grade at this point, but it is interesting to consider the limitations of 5G and Wi-Fi. And I would look at the limitations of 5G and Wi-Fi. They hold so much promise. They're high on the hype cycle, or 5G is high on the hype cycle right now. Whenever anything's on the hype cycle and peaking, always look for its limitations so that you can plan for and understand when it starts to drop into the trough of disillusionment. And so these other frequencies are interesting to me and offer a interesting opportunity. How many? That's not nearly enough stories. Let's see what else we have here. I'm gonna save all these. I have 5 telehealth stories. 1, 2, 3, 4, 5, 6 telehealth stories. I'll whet your appetite a little bit. I'm probably going to do a whole episode next week on telehealth. That is absolutely what I'll do. One of the stories, Network World, Zeus Kerravala. Interesting. Zeus Kerravala. There you go. As the COVID-19 crisis grew, areas that lacked high-speed internet access couldn't benefit from remote telehealth exams. COVID-19 strained critical services, and he goes on to talk about the digital divide, and that's the part I'll share with you before we end the show. No single company has a technology or business model to single-handedly close the digital divide. Industry collaboration and small investments in expanding connectivity options is what will make a big difference in people's quality of life. 3.8 billion people, nearly half of the worldwide population, lacks internet access, limiting their access to information, education, and healthcare, according to Cisco's Inclusive Future Report 2020. Gaps in access exist not only in developing countries, but also in rural areas of impoverished communities in the U.S. Cisco called on tech leaders to direct their energy and resources towards developing solutions focused on global inclusion. This means creating broader access to healthcare and social services powered by cost-effective, efficient technologies that meet local needs. Bringing the internet to underserved populations could lift 500 million people out of poverty and add more than $6 trillion to the global economy, said Jonathan Davidson, Senior Vice President and General Manager of Cisco's Mass Scale Infrastructure. There's a bunch of interesting stats in this article, just talking about things like about 20% of the Texas prison system doesn't have access to high-speed internet, and without it, nearly 40,000 inmates cannot get telehealth services. I find that interesting. Rural healthcare, I find interesting. The pandemic was a global pandemic, so you had a whole bunch of areas that could not benefit from telehealth. We're going to have to consider this. Telehealth is really interesting. I'm hearing a lot of people talking about the solutions they need to put in place in the hospitals themselves, but we're going to have to keep this idea of the connectivity at the other end in mind as we're designing solutions. We're going to still need to have some either low tech or low bandwidth type solutions that we are considering. So anyway, that whets your appetite for next week. We'll do a pretty deep dive into telehealth and see where we're going. That's all for the news for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, HealthLyric, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health IT leaders. This show is a production of This Week in Health IT. For more great content, check out the website, thisweekhealth.com, or the YouTube channel. If you want to support the show, the best way to do that is to share it with a peer. Send them an email, let them know the value you're getting out of the show. Hey, there's a lot of ways to subscribe. You can do it on iTunes, on Google Podcasts, on Spotify, on Stitcher. I use an app on my phone called Overcast. There's a lot of ways to get the show. I get my show as well as several others, and right there on Overcast. It's fantastic. Anytime I go for a walk, I'm listening to a podcast. Please check back every day through the end of June as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.